Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and I'll take you through another extremely interesting and genuinely complex case. This case is going to involve multiple lesions, the use of numerous imaging modalities, and hopefully you'll find it useful. Once again, to make it interesting, keep it interactive, keep sending the questions. You also have the ability to watch live stream on the iPhone, but the site for the questions is info@ccclivecases.org, available at the bottom of your screen. So let those questions come. And without any further delay, let me take you to the cardiac cath lab. Samin, good morning.
Yes, good morning, and actually
Your team has recovered from its Christmas Eve celebration?
well, yeah, in preparation for it also. But the question which you said, that for the question to be answered and the comments to be posted, they can actually, all cases, once they are archived on the heart.org, they can put the comments, and then we'll answer those questions within few days. But sometimes within 24 hours, but definitely within few days. But with that note, I rapidly take you through this complex interventional case with my associate Anu and my fellow here, Sham and Narayanan. The interventional fellow is the Sham. This case, which actually happens commonly, patients with multi-vessel disease, we start intervention and we do a culprit vessel and then bring the patients back for further intervention. Now this actually highlights some of the technical challenges and our practical, what we are doing at present with the patients. Now, if I start with this case actually presented in early November with crescendo angina and multi-vessel ischemia on stress MPI. Cardiac cath revealed 3-vessel disease and EF of 60%. And I'll show you the angiogram in few seconds. Patient underwent DES of the circ-OM with the Zions V3023, and since then, patient continues to have class 2 angina and shortness of breath and is on maximum medical therapy. The risk factors are shown here with the AFib and end-stage renal disease. And this is a very important issue about end-stage renal disease, and because these patients have calcific vessels, and second is with the AFib, then what is the right approach? Those who need long-term anticoagulation of warfarin, how do you select and prescribe your antiplatelet therapy? At Sinai, what we do basically that everybody gets aspirin 81 milligram and then with clopidogrel 75 milligram every other day. And this is substantiated by our paper in JIC, where our experience we showed that this combination had the lowest stent thrombosis as well as the lower bleeding. Now this patient now, basically just to enumerate again, non-obstructive left main with a normal ejection fraction, multiple lesions of the LAD, diagonal, subtotal lesion of the OM, and there is 70% RC and distal RCA. Somebody pay attention. Yeah, and the bifurcation lesions of the LAD which involve the diagonals. And basically when we did this case, what we do is that we have with incorporated in our cath reporting system calculation of the syntax score. And this patient has syntax score of 34. So clearly what we learned basically, and we have actually established the protocol, which is a little busy, but this I have made it so that anybody can download and to use in their own cath lab. That is the syntax score of 33 and above. Those patients who do not have absolute contraindication for surgery, like MI, very old age, prior CVA, severe COPD, very, very obese, or are participating in the trials of interventional trials. So those cases, if not, those patients come out of the cath lab. The key is always that if you'd ask somebody options while patient lying on the cath table, everybody will say, do the stent. But key is that the patient has to come out of the cath lab and then make a decision outside. With a cardiothoracic consultation, either in the holding area or telemetry unit. Now, many times these patients and they come back to the cath lab again, but that is but then you have given the appropriate chance for a patient for appropriate selection. So this patient actually was done the same. We brought the patient out and patient did not want to go for surgery, and Dr. Anu brought the patient back few hours later. Sheath is still in place, and then put a stent in the OM2. And now patient, as I mentioned, some still symptoms, and we do test the platelet reactivity unit routinely now. Actually, with the gravitas, it has been questioned whether elective patient, does it have any value. We know it has a value in acute coronary syndrome, but we did it. Patient is fully anything less than 230 is good, and patient is reactive with that, 222. And now patient has been brought for this complex intervention, which Anu will take you through. Anu?
Yeah, so if you see the angiograms, LV function is normal, and the patient has had a pacemaker many years back. So this is the right coronary artery, calcific, moderate to severe calcium prox lesion, which is about 70-80% extending to the mid, and then there's a distal 90% lesion just before the bifurcation of the PDA and AV continuation, and again same PDA, you see the ostium 60-70% moderate size disease, moderate size vessel, and here the left main is non-obstructive, and our circ stent that was done last time looks angiographically normal, and prox LED is okay on that view, but here if you see there is 80% disease involving a large diag, so it's a bifurcation, the calcific LAD, the lesion is actually extending into the mid LAD, and moderate disease in the distal LAD, but it's a large size vessel.
But at the same time, the diagonal also, that it's basically the Medina classification become 111, which is very important, because now whatever you want to do, you need to take care of the proximal segment. Although in this view doesn't look that bad, but clearly that it's involved proximally, and we'll try to do a little better view, maybe areocranial to see proximal, but clearly complex calcific lesion of the LED diagonal bifurcation. Now, having said that, we actually, you can start doing.
Yeah.
What I'll do is, just briefly, knowing that it's a complex, will require multiple interventions, so that I will keep presentation to a very minimum. In next 5 minutes, or 7 minutes, for that matter, we'll complete our issues involving the case, but then highlight the practical application, that how to do these complex cases and safely, and also incorporate the newer imaging modality, which is the OCT. Now, basically, just to go back once again, appropriate revascularization choice and high syntax score patient, which I showed the protocol of Mount Sinai, and because we learned that these are the hard data, death, MI, and CVA at 3 years. Based on the syntax score and the number of patients, you can see that once you go to a 33 and above, the death, MI, or CVA was significantly higher in the Texas DES compared to the Cabbage group. So clearly, that first choice, based on the evidence-based medicine, as per evidence-based medicine guidelines, that you need to offer the patient Cabbage. And of course, as I said, the patient once they learn the data, then they make a decision. But key is that we need to present this. Now, also it highlights that once you have lowest score, actually the PCI does better than Cabbage, which we all knew. So this is very important. Then question comes in terms of revascularization. These are the 3-year data, and you see there is almost 7 to 10% difference in terms of revascularization. That once you go to a more complex cases, there is a higher revascularization with the PCI, means higher syntax score, but for the Cabbage point of view, it's like a flat. So the basically just point here is that once you go to a higher syntax score, PCI has a higher revascularization, higher death, and MI. The one slide sums it up. Second, bifurcation lesion, of course, various classification of the where the branch point and where the stenosis is. We use Medina classification, which is very simple, that proximal, distal, and side branch each gets a number 1. If there is a disease and not, then get 0, and therefore you, anytime you present the case, it's very simple to show. And of course, the type D, which is 111, like this patient LED diagonal bifurcation, is the most complex and the most common, because there is issue with the side branch closure because of plaque shift, spasm, and dissection. So we need to be careful. How can we take care of these cases appropriately so that side branch does not close? And one of the issue I always point, and that we learned from our earlier DES trials, that when the patient, when you put a stent in the side branch, the DES, and you skip and miss the ostium, what happens is that uncovered area comes back with restenosis. So that we also learned that if you're putting a stent in the side branch, better you cover the side branch, and that will lead to evolution of various stent technology, techniques by culotte, V, Y, crush, or kissing. Now what we will do, that next in our next webcast or after, all these techniques we actually have published in various our journals and books, that we will highlight one slide each of the various techniques, so that it will be another manual for everyone to have it. And if the question always comes, one stent versus two stent approach, and as you can see here, I put it very simple, 1S and 2S amongst the various randomized trials, 7 of them, and the combination of the TLR and the MACE with the height of the bar. You can see that in the beginning, on the left side, we were having bad outcome with the 2 stents. But look at the right side now, the last few years trials. Actually, there is no difference in the 2 stent or 1 stent technique. So actually, in our data of the SKS precise of 100 cases, 2 stent technique was better, and largely because it decreased the restenosis of the side branch. That basically is, so that what I would say, the people, that a lot of people are concerned about 2 stent strategy, but 2 stent strategy done correctly is okay. Not associated with higher MACE, TLR, or stent thrombosis as shown in this slide. Now, that also at the same time, there is a lot of work being done in the dedicated bifurcation stent design, which are shown here, which are basically 3 main groups. One is that you put a stent in the main branch, but then there is a side branch access. ABT Pathfinder with the Frontier is has been done with the bare metal. Then Invatec Twin Rail, Minivice, then BSC Petal, which is actually the work the first in man has been done earlier. Yomed Sidekick, Enteras Triremi, and Stentis. These are the stent have the main vessel, put in the main vessel, and then they have access to the side branch, and you can deploy the stent. Now then there are side branch stent which will open up at the ostium of the side branch, and you can then put a stent in the main vessel. These are the Triton and Capella side guard, and I would call it a Davex Access Plus, which is the conical shape through which you put additional stent into each branches is another kind of a hybrid stent. As far as the DES design, the ABT Pathfinder, Invatec, BSC Petal, and Davex are the drug-eluting stent. Others are bare metal. Triton actually is the first bifurcation stent coming to the United States, and the trial will start soon. And these are some of the pictures here. With that, knowing the last month, actually we had a lot of discussion and points on infrared spectroscopy which was used. I felt that we show another imaging modality, which is the optical coherence tomography, OCT. We have to show it live. Yeah. And then actually, are you ready to show live now? Yeah. Can we show it? Though now we actually OCT, we show the live, and then we will talk about the theory.
So, I mean, is this the right coronary artery or?
Yeah, we are actually doing the OCT of the OM where the stent was placed.
Previously.
And now it did not record.
This is from 1 month ago?
Yeah, this patient was done about a month ago. Now, which is, no, I just wanted to show if we are ready to show the live.
Angiographically, the stent looks perfect. So let's see how the OCT and the additional information we get.
Because it requires the washout of the, washout by the saline, hard injection with a dye or saline? Dye. With a dye. You want to try once again? Are you ready to acquire?
So, Samin, how often are you using OCT already?
Yeah. What do you need now?
Just inject hard.
Okay, ready? Right?
Puff, we did.
Okay, good. Yeah.
Hasn't shown anything.
Showed any?
Catheter was.
Huh? No. I think there are some technical issues. This happens with the new technology, and I will now hand over to Pedro Moreno, and who is, of course, expert in all the imaging modality, including vulnerable plaque. And Pedro, you just give us brief outline what OCT is, because there are a lot of questions. Are we going to use OCT in the future? Are we going to use IVUS in the future? What is good? What is bad? And just give us a little quick brief review on this.
Yeah, thank you, Dr. Sharma. Well, OCT is really the best technology you can have in the cath lab because of the tremendous resolution. Resolution is everything for imaging because you can quantify the structures of the vessel wall as well as the struts and the and the neointima that is covering the strut. This slide shows how you can see the actual layers of the vessel wall. You see in the slide the intima covered by a thin cap fibroatheroma with the lipid core in the middle, and then you see the tunica media with internal elastic lamina and the adventitia. This device, as I said, was developed in the 1990s by the group of Brzezinski, Fujimoto, Boma, and Guillermo Turney in Boston. And they have characterized beautifully all the proper composition for lipid, for necrotic cores, for calcification, protrusion, thrombosis, as well as normal vessel wall. Let's review quickly in the next 3 minutes the image of this anterior LAD vessel, in which you see in the upper right thin cap fibroatheroma that has been ruptured at the shoulder of the plaque, complicated by thrombosis, as you see highlighted in the slide. This kind of resolution you cannot even dream with any other technical devices. As I said, the best evidence-based preclinical data has been shown during the last 15 years from several groups that you can plaque characterize the composition. You can actually measure the cap thickness because of the resolution, and less than 65 microns will be a vulnerable plaque. You can also quantify macrophages. That was a very good study both in vitro and in vivo in patients published in JACC, and the response to therapy highlighted in the right part of the slide, how the untreated rabbits got progression from fibrous into lipid rich, and the treated rabbits with the statins got regression from lipid rich into fibrotic plaques. This is the take-home message, most important slide. You can see the resolution at the micron level. For your idea, a red blood cell is 8 microns. You can see macrophages, which are 12 to 18 microns. You can compare with IBUS disease at least 10 times more resolution with the OCT. Nevertheless, we have problems with penetration and the field of view, as well as the profile is a little bit limited for the OCT, specifically the penetration. Previous studies have shown that have been actually in press now in very good journals about the vulnerable plaque with the thick cap fibroatheroma defined by virtual histology. You can see here the classical VH necrotic core thin cap fibroatheroma, but nevertheless, the true necrotic core thin cap fibroatheroma is defined by a cap thickness less than 65 microns that can only be identified by OCT. This is very important, and is highlighted in this slide, in which you see in the upper panel a thin cap fibroatheroma performed about 6 months before, and an acute coronary syndrome from the same plaque with progression both angiographically and by OCT. You can see in the lower right corner the plaque rupture clearly showed in the slide with embolization of the necrotic core. What about coronary stenting? This is also a very important topic, because we know that stent thrombosis occur because the stent did not endothelialize. Therefore, endothelialization and proper coverage of the strut is mandatory for safety profiles in our patients, and we can tell this beautifully with the OCT, because you can see the neointima and the appropriate coverage of the struts of the stent. So we can conclude that OCT provides excellent resolution for visualization of vulnerable plaques and optimal stent apposition. It also identifies plaque prolapse and early stent thrombosis. And the recent technology that obtained the FDA approval for all of us that can be used in the Cath lab is the optical frequency domain imaging that can give you 5 centimeters in one pullback with one flush with excellent imaging.
And no, that's it. No flushing. No flushing, huh?
Yeah.
Yeah, that will be actually, that will be a very important the point, because one of the thing you saw it, you had to give so much flush to get a better visualization.
It's a dye.
Dye, yeah. I mean, flush with the saline dye or any, that a lot of dye need to be given for these cases.
Pedro, very, very nice and quick review. So one of the absolute practical benefits would be where you want to interrupt dual antiplatelet therapy?
That's a very good point. I mean, it's a clinical information that you can obtain to reassure in case you're doing a case and you want to see the stent proximal LAD, bifurcation stenting, you can image it. If it is properly endothelialized, you have a peace of mind in case you want to stop the dual antiplatelet therapy. However, this needs, of course, randomized prospective data to be absolutely evidence-based.
So tell me, Pedro, why exactly could we not visualize in this particular case? Was it the force of injecting saline? Why didn't we get a good image?
Well, we are analyzing the reasons right now. It's tough to say, you know, you can have issues with the connections, you can have issues with the resolution. So occasionally we have these issues, but today in vivo we have less time, so we just to move on and
I
do the
am
ROTA.
sure
we
we'll have...
still try to do it in the end. You know, we are trying to work out the point. You would pull back?
Not only that, I'm sure we'll have many cases to demonstrate that. Anu, which vessel first?
We are doing the LAD now.
Okay.
We already have the rota wire. We did the direct, same thing is if you look at the...
Now, why did you decide for the LAD first as opposed to the right?
Yeah, I think from the bifurcation and the angiographic point of view that we felt, you know, this patient has a multi-vessel ischemia when came in. So the disease was everywhere. That was the point. So we felt that one of the highlight we wanted to knowing the the tightest lesion has been taken care of the OM. So we felt that LAD diagonal versus RCA, there probably more learning point technical challenges in this bifurcation lesion than the right coronary. But all will be done. You're right. In this particular case, there is no issues because both lesions will be taken care today unless some complication occur. And that is what the principle of a multi-vessel intervention is, that you have to have a good result of one before you go to the second.
Samin, in the data you presented from Mount Sinai with the bifurcation results, which bifurcation strategy did you use there?
We actually used two bifurcations, the conventional stenting, which is basically put a stent in the main vessel and the side branch you go through if need to be, and about 30% of those 50 cases that require another stent in the side branch. The second was the kissing stent, simultaneous kissing stent technique, and that is what our the highlight of our Cath lab is, that we had excellent, very good results of the intervention with the kissing stent. We still do about 8 to 10 cases of kissing stent technique every month, and there usually are the large vessel that the side branch is almost like 3 millimeter, 2.9 to 3 millimeter, where we'll use this kissing stent technique.
Excellent. Anu, this is so routine for you, but take us through the steps and tell us what burst size did you use there?
Yeah, so if you look at the size of the LAD was about 3.5, and the tightest 90% lesion at one point, if you see, that's heavy calcium. So based on that, we took the 175. If you see just after the septal, you see the tightest 90%, and that's where that heavy calcium is. We took a 175 burr, and the same, you start right from the proximal, come out of the left main, and the 3 steps that we have gone over, that you just lose the knob, you forward, backward there, and then at the Y connector, and the last step would be just do on the Dynaglide, and then you start with your rota. It's 175 burr with the 150 to 155 RPM, and most of it, since it's moderate, I think just with one pass you will go all the way to where the tightest lesion is, and when you are there you start doing your slow pecking motion, and as long as the patient tolerates, you keep going not more than 20 seconds, come back, wait in the proximal LAD, and you saw just with the second pass we were able to do the rotablator, and then you do your final polish run, which is done, and right now will be coming out. Okay, the question would be the same. I know there is a deceased LAD. The plan would be the mid to distal moderate disease, which we want to leave it alone. So we did not do the rotablator at that area.
Excellent, valuable teaching points.
We are done up to the early mid, not the later
distal
part of the mid. Yeah, mid, truly mid and distal. But the question is actually, we were thinking about that if we need to, should we go with the 2.0 bar? Actually, that was precisely was the region in this particular case. The lumen was just about there, like 1.5, 1.7. Should we have gone with the 2.0 bar? That was the only issue. And the one, in retrospect, yes. But I always tell everybody, there is no need to be hero because bigger the bar, higher will be the chances of dissection and the slow flow. So that if you can get the same job done with the smaller burr is fine, because basically you need to remove that calcium. That's the purpose with the rota, that you decalcified it, and therefore now then question comes, do you need to do anything to the ostial diagonal with the rota or no?
I mean, still most people are going to be approaching these cases despite all the merits you state without the rotational ablation. So what, let's say if somebody is trying to approach this lesion without rotational atherectomy, what would be your next line of approach?
Well, I would say in this particular case will be reasonable, because there is for the mid LAD, the calcium is the highest in the mid LAD, right before the just after the septal. Put both of us. Yeah, that in that area you need to just then be ready that you have dilated that area, opened it up, whether you use a cutting balloon or use an angiosculpt, because you may need regular balloon will rupture. So either need a first non-compliant balloon, and I would say if I'm using non-compliant balloon, I'll use a wire first in the I will use two wires and try to use a modified cutting. So the high pressure, if does not open up, then you use a cutting balloon or angiosculpt. If does not open and not a dissection, then you may go to the rotablation. That's another approach. The right coronary artery, I would say that if you look into the right coronary artery, that actually is a very calcific.
Particularly in the proximal
in the
segment.
Proximal area,
right.
Look at that one. Let's see.
Well, the good thing about the right, I thought, was it could be just a one-wire approach.
Yes.
Okay.
Now, the other question also for us, why we selected the 175 burr. Though the tightest area, LAD size is 3.5, tightest area is one spot, and we could do with a 2.0. When there is a moderate disease, calcific, long lesion, it's better to go with the smaller burr size, because your total burden of the plaque that you're going to burr will be long, and we want to use the same burr for the RCA also.
Yeah.
Right. Samin, what about the use of FFR in this case?
Well, I mean, in this case, particularly, we actually using more and more FFR nowadays. But this kind of case, because of these multiple lesions, there will be no question in my mind. What we learn now, that FFR will be positive. Although when we have seen many of the isolated lesion, like discrete, even 80-85%, you see FFR of 0.9. This kind of multiple lesion, and so I can tell you with the experience now, we have gained quite a bit. I could not have answered that question in the past, but this case will have the FFR very significant, maybe 0.6, 0.7, both in the LAD as well as in the RCA. Diagonal is plus minus, and this is the point I wanted to make, that the focal lesion.
3 or 20 quantum.
Yeah. Now what we are doing is it's a 3 or 20 quantum balloon. See that diagonal being just those moderate lesion, particularly the ostium. This case, if we do the FFR of the diagonal, I won't be surprised it will be 0.9. But since this is a little different case, even if it is 0.9, what we need to do is, because we are going to crack the lesion at that, there will be a plaque shift. So that we going with the strategy that we are going to take care of this is the large diagonal with the balloon and stent.
Okay, so we are using this compliant balloon, which is 3 or 20 quantum apex, and same reason, non-compliant. The reason we want to use a non-compliant is after you done rotational atherectomy, knowing that the calcium has been, spec has been taken out, you can go high pressure to really crack the lesion.
So in previous cases, Anu, you mentioned that if the balloon dilates at 8 or 10 atmospheres, you feel that you have ablated adequately?
And same thing happened here, that at the 8 atmosphere, full expansion of the balloon here. Now, also it is a modified, now we can remove the rotawire. Actually, we don't need the rotawire there. It has opened nicely. The rotawire, after doing its job, because we don't need the rotawire for our delivery, but keep it rotawire for the RCA. Now you bring back, do it at the level, and see the wire we have protected the diagonal, and diagonal will require cutting balloon. Yeah. Okay, this is the 12 atmosphere.
2.5 to 1.5.
We can use a 2.5 cutting balloon for get a 2.5 cutting balloon for the diagonal.
Anu, what guide wires are you using for standard cases? What's your choice of wires these days?
Yeah, there we actually have used a run through is in our LAD and the fielder in the side diagonal. Now those are our usual, the side branches, the workhorse wire in our lab is a run through, and for some actually still BMW. The reason with the run through is actually it gives you moderate support and it's a little better than BMW in terms of 1-to-1 torque. So the run through and the fielder for the side branch.
By Valirudin for this case?
Yeah, and our ACT is 320.
Okay, now the key is that now we are going to just take care of the diagonal. Oh.
So I think it came from here.
Little, yeah, 1 or 2 bubbles did go,
yes.
but patient is fine. But there's, sometimes happen with these 2 wires. I did aspirate, but I needed to be a little more aggressive.
I heard the noise, I think.
So you're going to address the diagonal at this stage?
Yeah, we are going to use the cutting balloon to the...
Yeah, the diagonal also has a lot disease, but our goal is to take care of the first 15-18 millimeter of the segment, and rest just rely on aggressive plaque regression technology.
So the mid segment of the diagonal with that small branch you're going to leave alone?
That's our goal, unless we create a dissection or so, but our goal will be, and which should not be by good technique, we should not create a dissection, and we should be able to just put one is we thought that this is the 3-stent case, 1 stent in the mid LAD, then we put a 2 stents, LAD and diagonal being diagonal quite big size, V stenting coming all the way up to the ostium of the left LAD.
So there's been the celebrated cases in the last issue of Jack talking about a patient with 66 stents. How much stents maximally have you put in your cath lab?
There is one patient actually I have who had a 2 bypass surgery, and the patient had total 44 stents. So we are not there yet.
All right.
Not to the 66 yet.
Down.
Wow.
Let's come to the ostium.
2.5 cutting balloon?
Yes, and same thing with the cutting balloon. Since we are doing the native osteal lesion, you go anywhere between 6-8 atmosphere, and at the same time you make sure the ostium has nicely expanded.
You use Anu,
what you can do is pull back
same sizing strategy for a cutting balloon and the angiosculpt?
Actually, for the native vessel, what you do is you go a quarter size smaller.
Got it.
And if it is an instant restenosis, you can go quarter or half size bigger. Like this one is a 275 diag. We have gone with a 2.5 cutting balloon.
Excellent.
Good diag.
And same, pull back to the guide, reorient it so that your blades will change, and then went back and did a cutting. So we did a total cutting of the ostium 3 times, up to 8 atmospheres.
Well, 15 years ago, that's how we used to do DCA.
Right. Yep, that's exactly correct. Now, this...
you want to take pic? Yeah.
Yeah, that's okay if you take it out.
Samin, how old? The patient is 73?
Yes.
78.
So what would be your prasugrel?
No, in this particular
Not
case, no.
Because of the renal?
I would say that yes, we can use prasugrel, but if it is refractory or that does not have a high
Patient is
inhibition.
on dialysis also.
Dialysis, we have checked this patient because of this complexity, and this is what we were doing earlier anyway for many of our the high risk patients, which now has been to a great question, and I know there have been a lot of debates going on now, the interpretation of the Gravitas trial. And I can tell you that a lot of people talking about that it was underpowered studies and all this, that's absolutely wrong. You can have underpowered study, you can do 100,000 cases if there is a odd ratio is 1.01. So it's not a underpowered, it just basically is, it does not make concept in the elective stable patients.
3.5?
Yeah.
3.528.
Yeah. 3.528 times 2.
Samin, this to me is the real teaching value of this case. Take me through the various considerations which are going in your mind about the bifurcation stent strategy here.
Yeah, 3.528.
Yep.
Promus.
Or 3.28.
So,
Yep.
despite what you showed in your presentation, a majority of the people will just do a 1 vessel stenting of the LAD and ballooning of the diag.
Yeah.
Not a not a wrong approach.
Yeah, which is not, although again, as I said, now this, see that ostial diagonal has not completely opened up yet. So this case is very likely will close after your stent of the LAD.
You
So
don't
which is
think,
okay.
you don't think you should have put in a 2.5 balloon in the mid segment there of the diagonal?
Well, I mean, if we need to, we are just thinking
No, I
actually the
think-
distal area after the ostium now has become a little more significant, and we may decide to put a little more. That we may decide to just put a stent there also, that both two stent cases, two in the LAD and two in the diagonal. Because as the point you made, it is looking more significant now than before. Yeah, good.
So this is
Wait.
what
It's
size?
a 3028.
Okay. Which, what stent type is
It's
it?
a Promus 3028. Huh?
Right.
Yeah, and then we require both two stents in both the LAD and diagonals, two in the diagonal and two in the LAD. Yeah, lesion goes up to there, up to like 2 o'clock position, right?
Okay, some die. Okay,
Yeah.
okay. I pull back a
Yeah,
little
pull
bit.
back 1 millimeter.
Samin, would IVUS have given you any additional information in this case?
But I mean, again, for many people, they rely on the degree of calcium, the vessel sizing, and so yes, that is one. And then I would say that and some just rely on their own angiographic point of view, and that I call it EB IVUS, eyeball IVUS, just like eyeball QCA we used to have. So basically, that angiographically, the case which you saw here, the calcium, and actually at the level of the pacemaker, see the calcium, although it is on that picture, and the picture is overlapping. Once you see that angiographic calcium in Mount Sinai Cath Lab, majority of them, I know I cannot say 100%, but close to 95% of cases will get a rotational atherectomy before putting a stent. And maybe, I would say that I take a pride in that maybe that is why these complex cases, we still have a proximal edge. So go in. Now, once you come out, you always open the proximal edge because you are going to put a second stent to funnel it up, knowing that the stent you deploy, this the everlimus giants or Promus at a moderate pressure. You otherwise create a distal dissection. So proximally now, you can go to 14 atmosphere. We deploy that about 12, and now so that now second stent will go. So before going into it, we'll take a picture and we decide, do we put one additional stent in the diagonal, because that diagonal lesion will not be covered by a 28 millimeter stent. One second. The long, long stents take a lot of time to deflate, and we actually, many people use in the long these stents the high further dilution of the contrast for the rapid deflation.
Anu, 7 French based
Yeah,
guy?
we have a 7 French Mark VL 35 guide. I think we use VL for most of the left system, though we used to like FCL, the CL curve for the LAD. Most of I think left side we use VL, and majority of the cases are done with the Lima guide. And you see all our cases that we have shown are done by the Mark guides here.
Wow.
The LED is
See, this is
looking
the
all right.
typical that wherever you put a stent, the distal area will look a little more inflamed. But we are not given any vasodilator. I mean, there's no question in our mind that disease was always there. But that we will decide. Our goal was that that probably will be more of a spasm, little vertical displacement of the plaque. But let's concentrate on the diagonal first. Do we put 2 stents in the diagonal?
I would just dilate the mid segment with the 2.5
I think 28
balloons.
will cover it.
Huh?
It should cover, yeah.
28 will cover it. Oh, no, you want to do a V.
Yeah, no, but will it come all the way up to 2 millimeter into the main vessel?
No.
28 will not come, it may come. Let's get a 2.528 Promus.
We should have started right.
So you don't want to dilate
Means we
that
should have
mid
probably
segment
started
of
right.
the...
No, but we can put one more. Now, I mean, if
no,
the
we are not
question
doing
comes that do we put a third stent in the LAD,
No,
in the mid to distal segment? But we'll come back to it. Let's just see what happens here first. Huh? We put a stent in the mid to distal LAD. I think we need to do, yeah. Unless this goes into a distal portion of the diagonal. Let's see quickly and we'll decide. You're right that in this particular case, if you need to put a stent in the mid to distal LAD, do it now rather than going through the complex those V stent technique. But we'll see it now, where it is. This was actually, Samir, you pointed out early that was a lot of disease in that mid to distal LAD.
Right.
It clearly was. So now, I think this alone will not cover that area. I think let's go distal, and we need to cover
No,
this.
we are okay.
No,
We are
we
okay.
cannot.
Well,
Yeah.
the diagonal stent is clearly covering both the segments, so
Yeah, we are good.
Huh?
We are good.
yeah, exactly
Will it
right.
be okay?
Yeah. I mean, proximally, how far you have to come back, right?
Good. Then fine, leave it there. Then give me a 3-0, another 3-0, 23.
Anu, you want to slightly either
We'll go 1 millimeter in and then come back.
no, angulate the angiographic view a little or decrease it. We, you know,
No, you have
the
to see
circ
how
is
far
kind of
proximal.
totally covering our.
This will be okay.
No, not that way. No, I'm talking about
Proximal.
LADE.
Yeah,
means
proximal.
how
Ostial.
to the ostium.
Yeah. This
We
one.
can't create another ostial.
Yeah. Now that's a very important point because you need to bring them proximally. And what we can do is once we align it here, we can go to a RAO, the RAO caudal view. And RAO caudal will tell us where the stents are. Because here we actually have the camera is 42 RAO and cranial about 35. Still we have an issue in terms of full coverage or visualization of the ostium. Now once you're putting a 2 stents, although they can go through the 6 French, we are putting a distal first?
Yeah, yeah.
Yeah, hello. That's what we decided.
Okay.
That's good. See?
Now, but do we need a 28 for the distal?
Okay.
Yeah.
Sine,
Okay.
didn't we say before we do the bifurcation, we are doing the distal? It's good.
This will be okay?
I pull back.
No need to come back a little bit
Yeah,
there.
yeah.
1 millimeter only.
So this is
Yeah.
a 3-5 promus, 3-0
thi-
promus.
Yeah,
3-0.
28, 23.
23.
Got it.
Right? We go up now.
Yeah.
So I mean,
Which
how
one?
much, how many millimeters do you
Yeah.
compulsively try to overlap?
Just one cell, and particularly with the stent boost, it helps quite a bit.
Yeah, 3 or 23, go.
Okay.
And how high are you going to go up here?
Here same, that I'll go 12 atmosphere, and then
that-
pull back and inside. Yeah, yeah.
And then go with the
And then go a
non-compliant.
little higher pressure. Yeah. In this one, I think because a lot of vertical displacement, you want to go 2 millimeter distally?
No.
Okay, then let's pull back a little bit. If we need to, we can come back a little later for the distal segment. Yeah, good, good. Yeah. Here we go 14 to 16 atmosphere, and clearly that after rotablation, they should be able to see the thin strut. Now, also another technique for this thin strut is in the cobalt chromium of everolimus that do it the first inflation for about 25-30 seconds if we have not done the rotation atherectomy. Otherwise, we just few seconds up and down. But it takes little time for stent to expand. So what our policy is that we do a first inflation for about 30 seconds and then second inflation for about 5 seconds. So the 2 inflation, because second inflation will the stent will expand with the least the more uniform expansion of the stent, so that the balloon will expand a little more uniformly, because first one will open at the resistance of the plaque. So now we have done this. We have here.
Show me,
See,
Laura.
yeah. Oh, 1 second. Here you take care. You hold the stent and wire. So clearly you have to see. So I'm pulling this out because not uncommon. They will crisscross. Good. Pull this wire a little bit. Good. Yeah. We have another 3023.
Wait.
Yeah. Yeah. We cannot aspirate, right? We just have to go forward.
No, you can.
Huh?
Little bit, very little. Slow. Good. Okay.
Okay.
Yeah, looks good.
Good. Yeah. Very good. So now we are ready. Okay.
Oh, stupid. I think that's a wire.
You don't think you need to be a few millimeters?
Yeah, no, we are going to pull back.
Yeah,
At the
okay.
time of deployment. Yeah.
Okay.
Good. No.
No, 23, 28 you took.
This is the 23 now. If need to be, the question is the proximal. I think otherwise will be a too much overlap. Let's go again. Yeah, now because we have done so many movements, I would say if I technical point of view, if our decision was to put a stent in the mid to distal LAD, should have been done first before putting a stent into the diagonal. So what will happen is by this multiple wire movement, what you are going to do is you are going to just the intertwining of the wires and make difficult in terms of your advancing your stent. Yeah. Okay, good. Bring the other one. Yeah. But first we are here. Good. Ready? No, 1 second, 1 second. We document here first. Both proximal dots overlap. Good. Now, it's a covering. We just want to make sure all the diagonal may go 1 millimeter in here first. Go. Diagonal 1 millimeter, that one. So it comes overlap. No, too much. Yeah, good. Good. Yeah. You needed 1 millimeter more. Diagonal. Just 1 millimeter. And then we'll go to the caudal view. Now we're going to miss both.
Show me some dye for the dye.
Okay. Yeah, because there's the key that can we compare the, just do one,
Okay.
right?
Yeah,
Go
perfect
to the
now.
caudal now. Good.
No, move something. Okay, is something at the touching the camera? It's moving very slow.
I bet you it's going
Yeah.
to be the skirting of the.
Okay. Good. Just 1 second. Yeah. Good. They have come nicely. Remember, there was no proximal disease. We go back again. We just do the same view.
So this view you went there to
We
check
just
the
wanted to
proximal.
make sure that we are not coming in back into the covering the circumflex and so.
Got it.
Yeah, I have not. Now, question is, I still think the diagonal should go 1 millimeter in. Remember, there is a very little
Can you
disparity.
show me some dye so I know exactly how much I have to go in?
Okay. Yeah. See, because
Well-
right now the diagonal stent is in that lesion.
In the mid portion of that lesion.
Yeah. So just we need a 1 millimeter tuning up adjustment. Good, good. Hold it there. Huh? No, fine.
Good. Go up.
Go up. Okay, here.
Okay, but
Okay.
LED is too much in.
Yeah, that's fine.
Go up.
Okay, we are going up at 10 atmosphere both.
You may lose the subtle.
Okay, for about 15-20 seconds, patient tolerating very well.
So that's
Down,
your
down, down.
step number 1.
Yeah. Okay. Negative. Both simultaneous inflation and then simultaneous deflation. And then now you give a little breathing room, let the blood flow. And now you go, because the whole question comes with Anu pointed out, that there is a little more overlap of the stents at the level of that septum. So now we'll go individually. And the question is which one should be more, that does not matter. So now we are going with the diagonal first, which is about 12 atmosphere.
Look at the ostomy, the diag
Yeah.
nicely expanded by the cutting balloon. This is
Yeah.
a very important
Yep.
step.
The deflate again, wait 1 second, yeah. It will take a little time to deflate. Now you go up. Then the LED, that's a third.
12.
Yep. Good.
High pressure, fully expansion.
Yep. Negative.
Deflate.
Again,
And now
few,
it-
because the last inflation, and that actually become more important for the distal left main when you are totally occluded RCA, that you need to have the last, because it may require giving a patient is hemodynamic unstable, give little neosynephrine because you want your final inflation well expansion, okay? Go back again, but patient here is tolerating very well,
12. Huh?
both at about 10 to 12 atmosphere. Yeah, okay?
Down.
Down. Negative, good.
Should we go further for the LED? I think we have good overlap. We
Yeah.
don't have to do.
The
Huh?
overlapping
Yeah.
segment, yeah.
We don't need to go in between.
So this technique have the advantage that you don't have to
we can
recross
do
or kiss balloon.
Yeah.
You know, the V.
Go in for the LED.
1 second. Yeah, let's take the diagonal out.
Okay,
Yeah,
go back.
here. Yeah, do this now.
Yeah, I'm going to the LED now. In comparison with any other bifurcation stenting,
Yeah.
the V doesn't need to recross and kiss balloon. The other ones, all of them should be finished with kissing balloon.
Now, important point, see, look at the guide is out, okay? When we are doing this, once if you are deflated, good.
Yeah. Now, question also comes that distal LAD, do you want to do a little massage? Because it looks like there is a vertical displacement of some of the plaque after that. Although this is...
I think it looks very good.
I would leave it alone.
Yeah. I haven't still seen how the diagonal looks in the mid portion. I think that should have been covered very nicely also.
Now you have to be very careful when you're, see the guide gets sucked in, the wire goes distally as long as, and now you can take out both the balloons same time. You got to be showing your fingers. What do you?
So, I mean, a very interesting question has come through. What percentage of your patients' PCI are same-day discharge now?
Now, actually, the elective patients are almost, no, keep the hands on the side. Yeah, the elective overall now is about 32%. But from the elective point of view, almost 2/3 of the patients are either discharged same day or they're counted as ambulatory overnight.
Yeah, looks good.
Now you can see here. Now, are we ready for another shot of the your
OCT will need a new catheter. A catheter, same. Every time you try to come out, since it is a short monorail, probably destroyed.
Real idea.
Leave it. I take out the wire.
No, but question: do we go to the circumflex and do the another?
Proximal LED we have to see.
Yeah.
Okay.
Okay. Now, key is here. You need to see the proximal LED, as Pedro pointed out that there should be no dissection, and which is
very good.
Yep.
Samin, you have some options here. I'll let you make your decision. I think we have a possibility either demonstrate the OCT or chase the right coronary artery with 5 minutes to go.
Yeah, right actually will take a little time. But you do that. I think our purpose today was the same. The right will be do the same, the rotablation, and then stent. And here's that because Medina classification wise, right coronary artery had a proximal, distal, and nothing in the side branch. There is a 1-1-0. Therefore, proximal, distal, and the PDA being the main vessel. So that in this particular case, our goal is rotablation proximally. I don't think distally we needed rotablation. Just do a PTCA and then put a stent across, and then one stent in the RCA. Having said that, I think what we should do, our goal was today, just show the new technology and
so the right you'll probably use the 175 rotablator and
same.
2 stents.
We'll try to use the same, and I think that for the right it may require a bigger burr, but same. What we will do in those cases, that very simple, that we need to after doing a rotablation,
show the laser light.
Yeah.
You can show the laser light here.
They're not showing.
Camera.
Bring the camera here.
Showing our finger movements. The guy is standing there.
What we need to do is that clearly that in this case, after rotablation, we'll dilate with the balloon. If cannot crack it, then go upgrade the bar. Yeah. And you want to show?
Pedro, based on the angiographic appearance and what appears to be a satisfactory stent apposition, what do you think, what would you predict would be the OCT finding?
Well, actually, we move into the OM
circumflex
now.
Also, right?
Yeah, we move into OM, but
otherwise,
Otherwise,
what are the criteria of OCT stent expansion or so? Yeah.
This is a very crucial and timely question. There is a committee right now that has met both at the ACC and at TCT trying to develop the actual standards to interpret the images on appropriate coverage. But we believe that if you have at least, for chronic stents, if you have at least 1 layer of cells, you are endothelialized, and in acute stents, you just measure your acute gain, you see the stent apposition, and you see your stent expansion. it is much better than the IVUS because, of course, you have much better resolution. So you can see the black holes in the underexpanded stents, and in the chronic DES, you can see also the positive remodeling that the vessel has because of the drug.
Pedro,
So-
how many cases have you done with the OCT already?
Yeah, we have done probably about 50 cases now.
How much do you think is the learning experience one needs?
No, it's very fast. You really is such a easy and clear-cut visualization of the vessel wall and the struts that really the only issue we had to learn was when we do SKS, bifurcation, simultaneous.
So
piston
learning
stents.
OCT does not require a 5th year of interventional cardiology.
No.
All right. Good to know that.
Yeah. And,
Samin, a very important question is going to come here, which truly is one of the most practical teaching point. I pose this question both to Anu and to you. Follow-up of this patient.
Right. This kind of patient, we know that the patient with the left main, still some complex cases, you can do angiographic follow-up, but this kind of patient will do a clinical.
So at what time period
look at
would you do okay, let's concentrate on the OCT.
Beautiful.
So now you can see the 3-layer structure of the vessel wall right now. You see the intima, which is opaque. You see the tunica media, which is lucent. And then you see the adventitia, and you see one plaque you could see at 7. It's a long plaque. You can see it there, and then you see in the proximal probably an artifact. So we have seen that lumen-wise, the circumflex is excellent.
And stent?
And the stent positions are also pretty good.
You want to do some
Okay,
post-processing of the stent struts?
No, she just showed the intimal hyperplasia. You can
If it is.
higher mag. Couple of
They have
struts.
the key is that it's a one shot and takes how many seconds to do the 3 seconds?
Yeah, it's in 1 second you see 5 centimeter.
Yeah.
So it's an amazing speed.
How much dye did you
See
end
the
up
plaque
using?
there?
20 cc.
About
See in the distal vessel, you see the plaque go in, Pablo?
Plus you need to do workout so that your
Now the struts, you see
fingers
the
are
shadows of the struts, and you see very little coverage of the struts. There are, the stent was deployed when?
1 month ago.
Now
A month
question
ago,
to
yeah.
you is, Pedro, very
Yes.
important question. Leave it at the level of the stent. Is this stent endothelized? This patient,
Yeah.
not today,
Yeah.
2 months later,
Yeah.
we comes
Yeah,
back and
no,
we
I
do
understand.
OCT.
Yeah.
Can I stop the Plavix clopidogrel for few days before patient going for surgery?
Yeah, well, in this
Zoom.
case, you can
Zoom.
easily
Zoom.
tell that there are some struts that are at the vessel lumen almost, attached to the vessel
to show
wall,
how
but
tight.
there are
Yeah,
some that are
no,
not
no.
properly endothelialized. There are others ones like what is seen right now with the arrow
You can
that
make
you
like
can
that.
easily see the strut and you can see the endothelium on top of it. So it's very important to analyze the whole stent in the 360 cross-sectional area. So here we're measuring the lumen. You can see it's automatic. There's no risk of
did you get that
underestimating
other
or overestimating the lumen. It's a wide open vessel. Very little neointimal hyperplasia. We can see some. We're gonna get the measurements right now.
But more
So
important is,
at
talk about
1
the-
month, at 1 month, at
people
1
to know.
month, we have learned that it takes about 6 to 8 weeks to properly endothelialize in the bare metal area. In the DES,
Can
to
go
properly
bigger.
endothelialize, it takes about 4 to
You
6
see like a
months to
square
be on
coming
the
in, no?
safe side. That's why the initial FDA approved for double antiplatelet therapy was 3 to 6 months for each of the stents. So I wouldn't expect from 1 month to have properly endothelialization.
No, but what I would still say, can we zoom one of the strut?
Yeah, let's do that.
Can we remove this?
Go more proximally.
Yeah, the tick, yeah.
Go more, yeah.
Anu, can you, when you inject 20 cc, can you dilute the contrast? Or
they no recommendation not to.
so that is also an important consideration with the dye load also,
Yeah.
no?
And therefore, many times the assist device may come handy for this
Right.
purpose.
Excellent.
That you give about 10 to 12, and so,
And forceful.
yeah.
Okay,
No,
let's go with the.
Measure free. Go ahead. You want to measure it?
okay, no, we don't need this.
Very
Fine. But the key is, yeah, good, beautiful.
good. Let's go
can
more
we just-
proximal. Let's go more proximal.
No, the 1 second. Please, can I just suggest your stent strut on the top?
Yeah.
Yeah.
Here.
Can we magnify that stent strut?
No, can't.
We
Just
don't
put
know.
a area of no? Yeah, that's where we need to see, right? I mean, you
Yeah.
need to zoom it because a lot of work in the OCT is post-processing. That once you acquired, then you do all these
can you get
parameters
this?
in terms
How
of
do you zoom that?
magnify and see the intimal coverage. And the question they say that if your stent covered is like 65-75% is good enough that it's a stent has been covered by the endothelial layer and maybe okay to stop the antiplatelet therapy in those rare cases. I think with that note, it looks like that we need to get a little more technically savvy. But we have shown this beautiful case of the IVUS with this case with the
small square will
OCT
come,
with the complex
so you can see
LED
it
diode
inside.
bifurcation. And I think we come back
RCA.
to the point. And of course, we'll do the RCA offline. And if I can just sum up with my last slide, that the newer imaging techniques such as the OCT may help us in future to better manage our PCI cases, especially DES as regard to the depth interruption. To me, I think the OCT, the IVUS is very good in terms of what we do, in terms of stent expansion, see the apposition, whether there is a positive remodeling, as dissections and so. But for the OCT, to me, will be the very important for the depth interruption. Okay. Secondly, midterm 3-year data unfavorable for DES in multivessel disease with high syntax score of 33, and these patients should preferentially be referred for CABG.
Okay, I got it.
Lastly, the bifurcation lesion interventional technique continue to evolve. With 2 DES technique should be decided upfront in a long angulated large side branch lesion rather than bailout strategy, and if done correctly is no longer associated with higher SAT or restenosis versus 1 DES strategy, which I have shown. And then of course optimal technique, and with that optimal imaging technique. Anu finally got the magnification. If we can just show this the last 1 minute from Anu, and then we will conclude our this morning symposium.
So actually, if you see that we were able to magnify, you see the stent, I think the strut, and then you will be able to measure it. I don't know how many microns. You can see that it looks like there's not a lot.
You have a layer, probably a layer of cells.
One
on top
layer.
of the upper and the middle as well. So with the resolution of 10 microns, if you see a layer, you know there are a cell at least or 2 cells on top of that strut, and it may give you some reassurance in this specific evaluation for this strut. As I said, you have to be careful and evaluate the whole process, the whole stent, in this careful decision making for dual antiplatelet therapy.
Well, right, I can tell you the last word on this. I don't know about Anu and Pedro. I saw one macrophage crawling over that stent strut. With that note, I think we complete our this morning symposium. Thank you very much. And
a quick final question for you. Thallium stress test at what time period?
usually in these cases we are done about 9 months. 9 months to 1 year.
Excellent. So, you know, in many ways, the last image which you demonstrated almost gives you a scanning electron microscope kind of image. Anu, excellent demonstration. Hopefully, there have been many lessons our viewers would have picked up how to treat a genuinely complex case with the severe calcification, bifurcation. Hopefully findings for the OCT as well as some didactic have been useful. We conclude this session today. Congratulations Samin and your team for another outstanding demonstration. Our session number 19 is going to be in the new year on January the 18th. We'll see you then. And in the meantime, key in your questions and hopefully we'll try to answer all of them in the archived case. Thank you.
All right.